Hello, my name is Dr. Carl Michel. I am a practicing foot and ankle surgeon at Genesis Foot and Ankle Institute, as well as board member of T. Ward Jefferson Medical Society, where I currently serve as parliamentarian, health fair, and health education chair. T. Ward Jefferson is made of healthcare professionals dedicated to improving the health and wellness, access to care, academic and career opportunities and the quality of life of our underserved populations through the provision of healthcare, education, career exposures, and youth development services. Thank you for electing to take this opportunity to learn. We hope you find this offering valuable in your everyday life. If you would like more information on T. Ward Jefferson Medical Society, please visit our website at tljmedicalsociety.org.
Next, in our series on opioid education, what makes young people so vulnerable to addiction?
The adolescent brain, which still struggles with this idea of invincibility and being invulnerable and not having to worry about the consequences of one's actions, makes it extremely vulnerable when it comes to substance use.
We also look at a new approach for parents.
So that's a really important thing, is being honest with people and telling them what can happen. Not just drugs are bad, not just if you use this you will die.
And new tactics for doctors.
Many times we're learning we can get away with other prescription and over-the-counter medications. And so we want to be maximizing and utilizing that. We also want to make sure we're having the conversation about what else is going on.
Thank you all for joining us. I'm Sandy Collier. And joining us on this session is Dr. Akiva Dam. And he was with us last session, and we learned so much from him, and we thought we'd bring him back again. Dr. Dam, thank you so much for being here. But before we get started, why don't you tell us a little bit about yourself and your practice?
Well, thank you for having me back. It's a pleasure. My name is Dr. Akiva Daum, and I am a board-certified addiction psychiatrist and general adult psychiatrist. At my practice in Coral Springs, I see a multitude of patients, adults, children, adolescents, struggling with general mental health conditions as well as addiction conditions. My passion is working with individuals struggling with opioid use disorder, alcohol use disorder, really helping them to be able to achieve recovery, sustain recovery, and live the life they deserve to be living.
So let's jump right into this because we have a lot of questions tonight for you. Let's talk about the brain. Explain the neurological developmental differences between an adolescent brain and an adult brain in terms of substance abuse.
The adolescent brain is still developing. So up until around the age of about 25, the frontal lobe especially, which is responsible for executive functionings, which are the areas of the brain where we look at, are you making the right decision? Have you thought this through? Have you considered the consequences of your actions? All of those pieces are still developing. And so the challenge is in an adult brain, they're able to think about, okay, what's the next step? What's going to happen after? What's going to happen if I do this? The adolescent brain, which still struggles with this idea of invincibility and being invulnerable and not having to worry about the consequences of one's actions, makes it extremely vulnerable when it comes to substance use. Substance use can lead to a lot of different consequences, as we've seen, as we've heard about, including continued use, development of addiction, making poor choices, which can really follow us throughout life. And certainly in that adolescent population, if the risk exists of developing and using a substance that is going to have consequences that far reach the normal consequences of a poor decision amongst an adolescent, those are exquisite challenges.
What are some risk factors associated with the adolescent population pertaining to opioid addiction?
So in an adolescent, if they end up developing an opioid use disorder, what can happen is everything else falls by the wayside. So we see school falls by the wayside, any kind of job will fall by the wayside. They'll start to put opioid use disorder, opioid using, and getting it, and attaining it, and continuing to have that use as the number one priority, which means everything else gets lost. So we see that individuals who struggle with opioid use disorder, especially as they are younger, have significantly more complications. We see impacts in their level of schooling, their ultimate socioeconomic status, what they achieve in life, and all of these challenges are pervasive.
What are some of the ways that children and adolescents gain access to opioids? Because it is a big problem, isn't it?
It is, and one of the number one causes and ways that people get access to opioids is through family and friends. Not necessarily people just giving it to them, but especially nowadays where it's, let's face it, difficult to get a prescription for a pain medication. People get prescriptions and they store them and they save them in their medicine cabinet. And so what happens is someone goes into your house, either a loved one, family, friend, and they use the restroom. And in the restroom they happen to say, let me look in the medicine cabinet, let me see what there is. And that can happen. It doesn't even have to be family or friends directly, it can be a friend of a friend. Oftentimes, right, we have parties, maybe not right now, but we have parties, people come into our homes. Sometimes we have people who come to do work on our homes or to clean our homes, which can start when you're an adolescent. You can begin, working. And so you have access to those supplies. And so that can be a big challenge. That's probably one of the number one ways that young individuals get access to these medications.
What is the role that parents play in helping to reduce the prevalence of opioid addiction in their children?
One of the important things that comes from that is many facilities, the police station, pharmacies, have returns. They have drop boxes where you can get rid of and safely discard your unused prescription medications. That's probably an important step, because if we take away that, well, I have this sitting in the medicine cabinet, then there's nothing to take from that aspect. Most of our adolescents don't have ready access to drug dealers or people to get them from illicit means. So if we take out that equation, people who they have ready access to, who have the supplies, that significantly decreases it.
How should parents talk to their children about the dangers of opioids? When is too much information and not enough information?
It's very important to strike a balance when you're talking to young adults, adolescents, children about substances. And I include children in there because, unfortunately, many of the individuals that I see, when you ask them, when was your first experience with a substance, they're in their teenage years or even their preteen years. So it's very important to have that conversation early on. And yes, you want to stratify it based on their understanding, based on their level of age and maturity. However, we also need to strike that balance. Many people find that the scare tactic is the most important thing. But the truth is that the scare tactic doesn't necessarily work. If you tell a child, if you use this, you will die, then when that doesn't happen, then they don't believe you that the other things you told them were correct either. I have a colleague, and one of the things that they explain to me that they use when they're talking to people about substances and how to talk to their children, they figure a straightforward approach is important and an honest approach, which the truth is if you tell someone, you know what, you could use this thing and you might like it. And the problem is, the challenge is, you might like it a little too much. And that opens up the conversation. That lets someone see that, sure, you could take a pain pill, and it might not necessarily be something that's going to kill you. You won't necessarily stop breathing. But what's going to happen afterwards? What if you really, really like it? What if you say, well, 1 was good, maybe 2 is better? And that is how we see the development of a substance use disorder skyrocket and really just cascade out of control. So that's a really important thing, is being honest with people and telling them what can happen. Not just drugs are bad, not just if you use this you will die, you will have all these kinds of difficulties and complications, but what will really happen and how will it happen, right? We want to make sure that we're being honest with these people and telling them it's not that you'll use and that's it. After one time you'll be addicted. Can that happen? Sure. But more likely than not, you use it, it feels good, and you want to use it again. And that's the challenge.
Are there additional risks for children who have parents that are addicted to opioids?
I think that there are risks. First of all, we know that there is a genetic component to substance use disorder. And so individuals who have a substance use disorder, there is a genetic risk for their children having substance use disorders. There's also environmental risks. So let's first talk about people who have active substance use disorders. Those children grow up seeing that this is normal, right? It's normal to have behaviors where you're putting the substance first, where you're using, where you're high on a regular basis, or the first thing you do is use so that you don't feel withdrawal, so that you can feel normal, quote. And so that's one of the important pieces that can affect the development of a substance use disorder in that population. Now, what about people in recovery? They still do carry the genetic components. So they still carry those risks. However, the difference is, and again, you want to stratify this for what age group your child is, but you want to make sure you have the conversation. And again, it comes into the importance of having that ability to say, you might like this. I struggled with this. This is something that runs in our family. In some ways, no different than if you have a family history of diabetes, you may want to make sure that your children are dieting, eating right, staying healthy, exercising. You want to make sure that they know that these are things that they need to be looking out for. What we don't want is we don't want children growing up in a house of recovery where they know nothing about their parents' struggle, and then they go off to college and someone says, hey, you want a drink? Or you want to take a pill? Or you want to smoke some marijuana? And all of a sudden they say, well, why not? Let's give it a try. Because unfortunately we do see that sometimes it skips a generation, where we see one generation is affected, the next generation is either non-affected or happens to be in recovery for the entirety of the upbringing of the child, and then the child knows nothing about the addiction and then develops themselves an active addiction. So these are all importance of the conversation that needs to be had.
For youth who are dealing with pain, say from some sort of injury, surgery, what can physicians do to mitigate the risk of opioid addiction?
What's wonderful is that a lot of physicians have really been taking care to do this already, and I think some of it is keeping it going forward. We have a lot of legislative restrictions for prescribing for pain medicines in the state of Florida and nationally as well. And so one of the things we want to start with is understanding what is pain and how do we manage it. Do we always need to manage pain with opioids? The answer is no. Many times we're learning we can get away with other prescription and over-the-counter medications. And so we want to be maximizing and utilizing them. We also want to make sure we're having the conversation about what else is going on. We know that pain is not as simple as I injured myself, now I have pain. Pain is affected by your mental state. What else is going on in your life? What else is bothering you? And so physicians really want to be looking at, are you seeing someone who also happens to be struggling with depression? Therefore, their pain is under less control. All of these different factors are important to look at, as well as we have medications that can balance between helping with the pain and helping with the mental state. And so we really want to try and see what we can do to utilize those to our advantage so as to really decrease the prescription of opioids when appropriate, And the other piece is, it's also important to treat pain appropriately when that comes, and sometimes that does include the judicious use of opioid medications.
We're talking about pain. Let's talk about the challenge of using pain as the fifth vital sign.
Yes, so the pain as the fifth vital sign came about several decades ago, and it came as a response to the fact that we were typically very bad at acknowledging pain, very bad at treating pain. And so that, amongst another number of factors, led to the start of the opioid epidemic. And so one of the challenges is we need to make sure that, yes, we are responding to pain appropriately, we're acknowledging pain, we are treating pain. However, pain is not necessarily the sole driving force, and the goal is not necessarily to eradicate pain completely. It used to be well, if you're in pain, that's no good. But the truth is that we have to make pain manageable. And so we do want to believe our patients when they tell us they have pain. We want to make sure that we're understanding and helping. If someone comes in and tells me that they're suffering, I believe them. It doesn't necessarily mean that I'm going to give them a particular type of treatment unless I've done my data searching to make sure that that is the treatment that's appropriate.
How do adolescents and children report pain? What are some of the signs to look for if an adolescent is displaying drug-seeking behavior? Can you talk a little bit about that?
So oftentimes, children and adolescents will display pain similar to how adults do. They will say they're in pain. They will be hurting. They might be moving slower, depending on where the pain is. They might, let's say it's an abdominal pain, they might be eating less or not eating at all. We want to make sure that we're monitoring for that, and we want to look for those inconsistencies. So when someone isn't being watched, oftentimes we see what's going on. So somebody comes and says, I'm in so much pain, I can't eat, and they're clutching their gut, and they're saying, and they're displaying all the right behaviors, and they look like they're in significant pain. And then you see them playing basketball 5 minutes later. It raises a significant question of, how much pain are you in? Now, I will say that there's a caveat with children and adolescents, especially where pain can wax and wane, and especially if they're among their friends, they may want to put on a brave face. But more often than not, we do see that there's consistent slowing. They may want to play basketball, but not be able to. They may want to hang out with their friends or engage in some kind of social activity, but not be physically able to, as opposed to someone who is legitimately not in pain, who will say, I can't, when no one's looking, all of a sudden they can.
What are some of the available resources for healthcare professionals when considering rehabilitation services for youth?
The short answer is unfortunately not much. One of the things that we see is that medication-assisted treatments, which can be very beneficial for opioid use disorder and are recommended as the standard of care, are hard to access for everyone. And unfortunately for younger individuals, the age restrictions are important to consider. Methadone and naltrexone both require you to be 18, methadone with a couple of caveats, but 18, you're not really a kid anymore. And buprenorphine, the age is 16 and up. So one of the challenges are that medications are not as readily available. The other piece that's challenging is that programs that are specifically geared towards children and adolescents are fewer and farther between. So we see a lot of programs out there for adults, even for dual diagnosed individuals, but what we don't see is we don't see a lot of programs that are geared towards those individuals who are 18 and under.
So, should youth be in rehab facilities with adults, or should there be age-specific facilities for them?
Treatment in general is best when it's done in your age cohort. A lot of times we see that, just like in other settings where if you mix individuals where they're at different maturity levels, we see risks of information being shared from older to younger, which is not necessarily a healthy level of sharing. Sometimes we have people leave treatment knowing more about certain things than we wish they would going in. As well as, I do want to take that opportunity, you mentioned rehab, and I want to take that opportunity to kind of remind all of our colleagues out there that rehab in and of itself is not a specific term that tells us what's going on. It doesn't tell the story. So rehab is this kind of blanket term where we say, okay, rehab, substance use treatment. The truth is that from a medical standpoint, we have different levels of care. We have residential level of care in which you're living on premises with 24-hour nursing. We have partial hospital program level of care where you either have boarding on site or boarding off site, and groups for pretty much 5 days a week for a certain number of hours a week. And then we have intensive outpatient treatment, which are groups that is a portion of the day and not necessarily every day in the week. And so I think that that's important for everybody to know when they're recommending treatment. Saying rehab doesn't necessarily help you to know what it is that you're getting and what it is that you're looking for. So we really want to try and make sure that we're looking for that level of treatment that is both accessible and matches what the child's needs are.
When is it the right time to make the decision for a kid to have intensive treatment?
One of the challenges that is probably the biggest factor is when we talk about the accessibility of medication-assisted treatments. Last time I was on, I talked about how inpatient levels of care aren't always the first choice to go to because medication-assisted treatments exist and are well entrenched with research that they are effective ways to treat substance use disorders, specifically in this case opioid use disorders, and have someone achieve recovery and sustained success. With this challenge where we have less accessibility and less age appropriateness for these medications, I think that in some ways the ripcord gets pulled a little bit sooner as it needs to be. We know that people are dying from opioids. We know that people overdose. The opioid epidemic, even though we have this other pandemic, has not decreased. In fact, it has increased. And with a lot more kids at home, we have a lot more kids accessing pain medications and other substances. And so I think that we're seeing and going to see those numbers continue to rise. With young adults and adolescents not being able to access medication-assisted treatments, in some ways because of availability or simply their age, then we do want to make sure that we are getting them treatment as soon as possible. The higher levels of treatment oftentimes are difficult to access, either through cost or availability. But what we also want to balance is what is the support system? A child or an adolescent who has a lot of support at home, who has a lot of people who are able to be there with them, monitor them, give them the supports and the resources they need, then they might be able to get away with less intensive treatment. Someone who doesn't have a lot of resources available to them may need more intense treatments to be able to achieve that early recovery, which will help them successfully attain sustained recovery. One of the other things that is important to do is to access mutual support meetings. Even in today's day and age where no one is doing things in person, or at least it's much less common,
Right.
There has been a wonderful surge of available online mutual support meetings. And there are meetings available for all ages. So they have Alateen, they have all sorts of different groups that are available. There's women only, there's men only. There are for different age groups, and I would encourage people to seek out their appropriate age group and really try and find a meeting that works for them in addition to the other treatments available.
Doctor, if you had the power to change anything in terms of where we are with substance abuse disorders, what would that be?
I think the thing that still screams in my mind is the importance of reducing the stigma associated with it. We still see people being blamed for having illnesses. People who are struggling with substance use disorders have medical illnesses, and they require treatment that is consistent with what our recommendations are, without unnecessary bias, without unnecessary opinions. We want to make sure that we are helping these people to achieve the goals that they deserve to be achieving, that they're capable of achieving, and setting them up for success. Not blaming them for having an illness, not telling them that they just need to hit rock bottom or aren't there yet or don't want it. We want to remember that we see patients all the time who, quote, don't want it yet. Think about the number of individuals struggling with diabetes or hypertension or obesity who haven't yet made all of those behavioral changes that we want them to. They don't necessarily take their medications as prescribed or watch their diet or exercise. We never kick them out of treatment. We never tell them, come back when you've hit rock bottom. When you've had that first amputation, come on back to treatment. No. We tell them, what can we do to shift? How do we help you be successful? And these individuals who struggle with substance use disorders are no different. If we're not able to engage them where they are, we need to figure out how to. We need to allow them to get the treatment that they need so that they can be successful. It happens, and it's possible.
And on that note, we have a lot of your colleagues joining us this evening. What advice would you leave for them this evening?
I would leave them with the idea that you can make a difference. You can help these individuals, and you can help someone turn their life around. I have seen so many patients who have done amazing things. People who have come into treatment where, when I was early on in my training, I thought, not going to happen. They're going to continue to struggle. This isn't going to be the time. And thankfully, I was wrong, and I was happy to be wrong because it meant that they were doing amazing things. And so I want to remind people that if you're feeling discouraged, if you're feeling like, I don't know what to do, reach out to a colleague. Ask for help. There are so many different available opportunities to get mentoring, to get free help, to learn how to work with individuals struggling with substance use disorders, with opioid use disorders. Get trained to be a buprenorphine prescriber. Learn how to use naltrexone effectively. Know about what the pros and cons are of different medication-assisted treatments, and learn what's available in your area. Increase your network. Make it so that you know who to reach out to, who to contact. The American Academy of Addiction Psychiatry has available mentoring for free. The Providers Clinical Support System has mentoring for free. You can nowadays reach out to the Opioid Response Network and get an educational component. You can get a mentor. You can get all these different things. People are realizing that we need to help people to be able to treat these conditions, help physicians, help healthcare workers to know how to handle this. And all of those different programs I mentioned, all free and accessible and available. And the people who are on it, I can speak to this because I'm one of them. It's a pleasure. It's a pleasure to work with individuals who have questions, who want to know what to do, how to help. And don't turn your back on them because they need you. And you can do amazing things.
Dr. Dom, thank you so much. It is always a pleasure to sit and just chat with you. You have a wealth of knowledge, and thank you so much for what you're doing for everyone in our community, your patients. I'm Sandy Collier. Thank you for joining us. We'll see you next time, and until next time, take care of yourself and each other. Coming up on our next episode, the emerging role of the chiropractor in treating opioid addiction.
Chiropractic care provides an alternative to opioids for pain management by treating the patient as a whole.
The shopping list of food to help with pain management?
To answer that question, there are certain foods that reduce inflammation, and there are certain foods that have been known to reduce pain.
And why managing pain early through physical therapy is so important.
Because once it reaches that 6-month mark and then turns into a year, now we're talking about reversing years of scar tissue, adhesions, and habits. Because a patient, they'll develop that as a habit of taking that medication.
Thank you guys for joining us. Very interesting discussion tonight. I'm Dr. Dom. We have a whole lot of questions for you, but for our audience that's there, if you have a question, please put your questions in the chat and we will try to get to all of them. But we have a list of questions here tonight. So Dr. Dom, let's start with this question here from a parent. It says, as a parent who is hesitant about talking to my teenagers about the danger of legal and illegal substances, how do I start a conversation with them about opioid addiction?
It's a very daunting task in our minds as adults and in the minds of parents of how do I start a conversation with a child about substances. The truth is that somebody else is also going to start a conversation. And so I think it's important to remember that you probably want to be the first one. And perhaps a great way to open it up is to say, has anyone ever talked to you about this? Has anyone ever mentioned to you about drugs, about alcohol, about, and specify, right? Drugs means a lot of different things to a lot of different people. So has anybody ever talked to you about tobacco? Do any of your friends smoke? Do any of your friends vape? All of these are inroads to begin the conversation. And I think if we all go at it in the mindset of someone is going to have this conversation with them, do I want it to be me or do I want it to be someone else? And the truth is, I think most of us would want it to be us. So that's how I would open that.
What do you think has more of an effect on the youth's susceptibility to addiction? Nature, genetics, or nurture, which are environment? What do you think? Let's talk about that.
It's interesting to look at how these pieces work. And so, we look oftentimes at the genetics behind an illness. And many of us know we ask a family history, right? And in residency in medical school, we're taught when somebody comes in and you think they might have depression, ask about the family history. And we all ask that and we all think about the importance of that. When we look at our actual data to say, what is the heritability of depression, of anxiety, we actually see that the heritability is fairly on the lower side. It's about in the 33% range. When we look at the heritability of substance use disorders, we see that it tends to be much higher, at least in that 40s to 60% range. And I realize that's quite a range, but the fact is that that's a large component of heritability. And so if we're learning, if we're taught to ask about the heritability of a condition that has a 33% heritability, then certainly we see that the heritability of something like substance use disorders, which are certainly higher, is important to take into account. Now, the other half of that is the nurture piece, the environment. What do our children see? What do they watch? What do they witness at home? What are our patterns? Do we come home from work every day and have a drink? Do we come home and smoke a pack of cigarettes? Do we smoke during the day, throughout the day? What are our children seeing? We see that there's this heritability as well as environmental practices. Many times we see that people who smoke, their children end up smoking. That is not just a heritability component. That also has to do with what they see as the norm. And we see that this can be, witnessed in many situations, for example, where the the person might have smoked or struggled with a substance before they had children. And then once they have children or those children come into their lives, that's not the case anymore. And so the children don't grow up seeing that as a norm. And so we do see that that's a piece to this as well, where many times the environment matters in addition to the genetics. And so I don't know that it's necessarily a one or the other so much as a both are very important. And one of the things that I mentioned earlier on was that we do see that sometimes substance use disorders skip generations. And so that also definitely speaks towards the genetic component as being important. So
We have another question for you. How effective are the partial hospital programs for substance abuse treatment? Wouldn't a 24-hour facility work best in most cases? That's a question from our listeners as well.
So 24-hour facilities, the challenge, as I mentioned, is access. And access in general, they aren't that common for adolescents. I mentioned before about the challenges with going to an adolescent program, or being an adolescent rather, and going to a non-adolescent program. So that's a challenge in and of itself. Access can also mean third-party payers. Third-party payers don't necessarily cover 24-hour treatment, and those that do don't necessarily cover them easily. There's a lot of pushback, a lot of headache, a lot of challenges. And so that is one of the challenges to 24-hour inpatient level of care as well. And when I say inpatient level of care, I want to clarify that residential level of care is considered to be inpatient level of care. It's just not inpatient hospital level of care. So access is a huge piece, because we have what is the availability, we have who's going to pay for it, because these are not generally facilities that are easily affordable by anyone if they're paying out of pocket. And if they're paying through insurance, we're reliant on the insurance companies to cover it. As far as partial hospital programs, some of the benefits that exist are they tend to be a little bit more available. They tend to be a little bit more accessible from the third party payers being willing to cover them. They also have increased availability when it comes to people being able to access those. It fits with people's schedules sometimes a little bit better. We're dealing with kids who are in school, presumably, and if you go to a partial hospital program where you are expected to still be attending school, we don't want kids to fall too far behind in their academics, because then that just perpetuates other problems and other stigmas. And as I mentioned, also stigma is a huge piece of this. So if someone is able to continue with some semblance of their life, as well as work on other aspects, that's important. It's also important to remember that a partial hospital program generally is still 20 hours a week. So it's not a low level of care by any stretch. It is less than a 24-hour, but it's certainly not a low level of care. It's not something that is necessarily a small amount of treatment. Now, that brings me into discussing about the piece as far as what about intensive outpatient programs, which are less of a level of care than partial hospital program, but still by that same token is a definite increase compared to outpatient. With that in mind, let's consider the fact that we're dealing with, let's say, 3 hours, 3 to 5 days a week. Okay, so again, we have kids who are then able to go to school, who are, if they're old enough to have part-time jobs, perhaps they're able to continue with that even, which is sometimes also important. We want kids to be able to have those normal aspects to their life and get the treatment they need. It shouldn't necessarily be that the expense of one versus the other, because then that just facilitates
more need to catch up, more feeling ostracized, more feeling outside, and then, of course, more stigma.
So, Doctor, we have a question here that it's a very interesting one here. If a minor is scared to disclose about opioid use to their parents and shares such information to their therapist, would that therapist still disclose his information to the parent, or should they?
So it's a great question. And um, in some ways, it depends on what the age of the minor is, right? So we have the age of you're becoming not a minor anymore when you become an adult. And then we have what age are people able to consent to treatment, to be able to make informed decisions. And that's not necessarily the age of 18. And that's different in every state, but generally speaking, we consider that when someone understands what's going on, when they're able to have that discussion, then they're able to be a bigger part of their treatment. So if someone says to me and they're, 16 years old, that they're struggling with substances, right? Let's put this in the condition of if somebody was pregnant and 16. I believe that depending on what state you're in, depends on whether or not you have that conversation with the parents. You may not tell them that the child is sexually active. So similarly, though, if their life was at risk, if they were having such intense risky behaviors that they were that something needed to be addressed, then that comes in the form of having the conversation with anyone where we have that discussion of, this is something where we do need to discuss it. I think a lot of times the biggest thing is you want to be transparent with the minor. You want to make sure they understand what are the limitations, what are you going to say, what are you not going to say, because that gives the opportunity. You don't want to destroy the rapport. You don't want to prevent someone from discussing what is going on. And by the same token, they may not be quite ready yet to open that up. But you may increase treatment in the meantime. You want to do what you can to help that person to get what they need treatment wise, and work with them on how do I talk to my parents about this, because it does eventually need to be discussed with everybody, because we also know that addiction affects not just the individual who's using, but their family members and their loved ones as well. So it is important eventually to kind of make sure that the parents know.
So we have another question, and you and I were talking a little bit about this before we started our session today. Why do you think the opioid epidemic has gotten worse during the pandemic? Or do you think it has gotten worse during the pandemic? And if so, can you tell us why?
I do. I think that the opioid epidemic, as well as substance use in general, has gotten worse during the pandemic. And for a multitude. So we have those individuals who had no struggles with substances beforehand, and perhaps developed a substance use disorder. And I'm going to use substance disorder as a base, because it's not just opioids, it's just also opioids. And so what we see happen was many people who perhaps had other coping strategies, had other things to do when they could deal with stress, when they could deal with frustrations. A lot of people lost those opportunities to utilize those skills during the pandemic. And so they turned to other options. Maybe because they didn't have work to go to anymore, they lost their structure. Maybe they started drinking more. And then when everything at this point is starting to open up, we're starting to do more, and people are getting vaccinated. And yet there are many people who have developed over the past 15, 16 months now this pattern of, okay, I drink, and then they're drinking more. And this is something that is coming to surprise them, where they say, wow, apparently this might be a problem now. So that's one aspect to this. Another aspect to this could be when someone is already using and they go and start using more because they have, quite frankly, more time to use the other things, again, that they were doing, they no longer are doing. Everything else was closing down. You know what? The liquor stores were still open. Drug dealers were still dealing and delivering. And unfortunately, that meant that that was more accessible than perhaps some of those other things that people were doing.
So, got another question for you, and this one, and all of our questions. We have great questions coming in tonight, and I'm really happy about this because this is such an important topic to discuss. Do you think that the stigma surrounding mental health has changed in recent years, especially with the commercialization of wellness apps such as Calm and Headspace, and also with celebrity endorsements from athletes such as LeBron James and Michael Phelps, just to name a few?
Yes and no. Yes and no. I think that people may be in some situations more ready to discuss about what their difficulties are, what they're struggling with, or even the fact that they struggle generally without sharing any specifics on what they struggle with. So I think that has in some ways been helpful, and I think in some ways it's almost served to normalize that yes, this is something that people go through, and someone happens to be one of them, and so it's okay. And meaning it's okay as far as I have something I need to work on. That being said, I do think that there is still stigma that exists, still stigma associated with mental health and substance use disorders. And the challenge that comes with that is oftentimes it becomes popularized, but they might leave out a lot of the factors that have been challenges along the way. Or someone might say, well, this person has this issue, but look at all the stuff they have, so clearly I don't fit in still, or there's something still uniquely wrong with me. And so in that regard, it's still challenging when it comes to the stigma associated with mental health and substance use. The other pieces that are challenging with the stigma are that it's it sometimes depends on what is the attractive illness at the moment. Um, and the shame in that is that there shouldn't be attractive illnesses. There shouldn't be something that's better or worse to have per se, and it shouldn't be something that's a fad. Um, we want to make sure that people know that these are conditions that people struggle with, and we don't want to minimize them, right? We also don't want to see someone say, well, this is what I've struggled with, and so I went to, 5 AA meetings and now I'm all better. We don't want to give that impression to people that, because then those who are truly struggling and who don't get it right away, or whatever terminology we want to use, that doesn't mean there's something wrong with them. That means they have a different severity of their illness. They're in a different place. And so in some ways, yes, it's wonderful that people are being more open and discussing about mental health, about their struggles with substances. And yet we want to make sure that those don't fall into generalizations where people still feel like they don't fit in.
How do you think, Doctor, with people preoccupied with the pandemic, how does that extra stress impact pain?
Stress definitely impacts pain. It looks like the next session will be about other non-pharmacologic ways to treat pain. It's very interesting. We really don't necessarily understand a great deal about pain at times. And yet, one of the things that we know from a while now is the pain that some people struggle with is very dependent on their circumstances, very dependent on other things going on. We saw this with soldiers that were injured in war, where they would have these major injuries, and all they would be worried about is their unit, the other people that they left behind, wanting to make sure, are they okay? And then similarly, we would see people who were not, didn't have that level of unity, of fraternity, of connection, who would come into these emergency rooms as civilians. And they would be, the pain that they would be mentioning would be so much just out of proportion to what was going on. And once we start to see, what, what are the other factors here? What else is going on? Oh, you had an argument. Oh, you have major depressive disorder that's untreated. Wow, there's this huge correlation between physical pain and emotional pain, emotional stress. And so that's why I mentioned at one point about the pain factor is suffering. If we think in terms of suffering as opposed to pain, then it really gives us a different picture of what we're trying to treat. And it reminds us that someone's coming in because they need help. And we just need to figure out what they need help with.
So we have a few more questions here, and very interesting questions. So here's one that just came in. Do regular family pediatricians have the means to assess and direct families in pursuit of appropriate treatment and or referrals for their preteens and young teens?
So, in a way, yes, right? So a pediatrician certainly would have the ability to ask these questions and evaluate, is there substance use? And as I recall during my pediatrics rotation in medical school, we would often open up the question and start to have the discussion. It's part of that, as kids start to be more independent and they do risky, right? We talk to them about, do you wear your seatbelt? Do you get into cars with other people? What do you do when you're in cars with other people? Goes along the same lines as the sex talk that we have in pediatrics with those patients. Now, that being said, there are specific rating screening tools that one can use. One is called the CRAFT, CRAFT, I believe. And you can find that online. And it is a series of questions where you just evaluate the risk of someone who is an adolescent who is making sure that they're not using substances, opening up that conversation. Now, as far as how far that support system goes, pediatrician may want to refer to a specialist at that point once they see that there is something going on. And that's when, they would bring in their reinforcements. In some ways, no different than if you figured out that there was a cardiac condition, you may treat it to the level of your comfort, but at some point you may reach out to the pediatric cardiologist to say, hey, we've kind of exhausted my comfort zone. I need assistance. And so that's an important aspect, is working within your level of comfort. Should you be asking about it? 100%. Do you screen? Yes. Do you refer? Absolutely. Who you refer to might involve calling in supports and referring to them first.
So we have, we're going to try to get to two more questions here because we're running out of time here, but this is so interesting. I really want to keep going as long as we can. Do you have some ideas on how we can improve the ability of our society to improve services or become more aware of the needs, the service offerings that should be available to meet the needs of youth that are in trouble or vulnerable youth? I mean, that's a loaded question, but I guess I'm sure you understand that question. What do we need to do? How do we improve services?
Right. So reducing stigma is I do think one of the biggest things. And so I think when you asked earlier about whether or not the celebrity and the app involvement has been helpful, and when I say yes, to a degree, I think that is helpful in some ways. I don't think it's necessarily flat out harmful. I certainly think that there are times when it can be less helpful. But quite frankly, for those individuals who are able to stand up and say, this is something I have struggled with, this is my unique presentation, and please don't generalize based on just what happened to me. As we build more of that, it becomes more of value, right? So when we have 2, 3 celebrities who have stood up and said, this is what I have going on, that doesn't give us a real picture as to what is going on in the world. When you have a slew of people stand up, right? This is one of the benefits of going to mutual support meetings, where you have a lot of people who can stand up and say, I have struggled with this. This is my story. This is not the only way to do it. This is how I did it. This is what worked for me. that has more value. We know that in our studies, right? When we do medical studies, when we do research-based studies, we never use just one person. We never use just 3 or 5 or 10. We use hundreds. And why do we use hundreds? Because the more information we get, the more data we get, the more useful we can make that generalizable. So one of the things is to reduce stigma on a generalizable scale. And I do think that there are pieces where there is that important aspect to remind. So whereas the celebrity's unique presentation may not be useful in regards to saying, hey, I have this thing, so if you have this thing, you know, it's the same as mine, right? I wouldn't suggest that. However, to have someone who has risen to a successful position, a position of power, a position of influence, to be able to say, my life wasn't always perfect. I had struggles. I had things going on. I had something that I needed to work through, and I still can get to where I am. That is a hugely powerful statement to tell someone who is young and struggling, to someone who is in a vulnerable position where they can see, you know what? Okay, so it's doable. So I can get past this. So I can work with this and succeed. And the more that this happens, the more examples people have, the more likely they are to see that it's achievable and attainable. I think that's the danger and that's the balance. Right now we're in that situation where a couple people are saying, hey, this is what I have going on. The more people that are able to open up and share, the more likely they are to openly be successful, because they're going to see it's not just one person, it's a lot.
Thank you. Thank you so much, Dr. Dom, and thank you for all of you for joining us tonight. Please remember, those of you joining us, to go and wait till the end of this presentation for your QR code so you can receive your CME award. And remember, one of you will win $100 after this event today. Dr. Dom, thank you. It was a pleasure. To all of you, good night. Take care of yourself and take care of each other. I'm Sandy Collier.
Thank you very much.
On behalf of our organization, we would like to thank you for electing to take this opportunity to learn. We also would like to thank our team and panelists for helping us make this project possible. If you would like more information on T.D. Ward Jefferson Medical Society, please visit our website at tljmedicalsociety.org.